Hello and welcome to this month's episode of the Atrium. This month we're going to be talking about the future of heart teams, and we're joined by no better person to talk about it than Dr. Michael Mack. Welcome, Dr. Mack, to the episode. It is a great pleasure to have you here to talk about this topic. What we're going to cover today is we're going to cover a bit about yourself and your background and your career, to get an understanding of who you are and why you've gone into this field and why you've specialised in the areas you have. We're going to talk about, of course, TAVR versus SAVR. We're going to talk about some of the other more techniques for valves and where we're heading with the replacement of other valves or repair. We'll try and touch on the future and what it's going to be. Is this going to be AI and where we're going with this? And then just get some tips for trainees in this ever-changing field of cardiac surgery, what to expect and what they can do. So welcome to the podcast.
Sounds ambitious. This is going to be 6 or 8 hours long or what?
Well, we'll try and keep it concise. I know we could talk for hours.
Sounds good. Well, thanks for having me, Alice.
Great. So a bit of a background to yourself. You studied medicine at St. Louis University. You then went on to do your internal medicine residency at the University of Minnesota, followed by a general surgery and thoracic surgery residency at the University of Texas Southwestern. You're currently a medical director of cardiothoracic surgery at Baylor Scott and White Health System and chairman of the Baylor Plano Research Center. And you're also president of the American Board of Thoracic Surgery. In the past, you've been medical director of the cardiovascular disease and transplantation at Medical City Dallas. You're past president of numerous societies: Society of Thoracic Surgeons, Thoracic Surgery Foundation for Research and Education, the International Society for Minimally Invasive Cardiovascular Thoracic Surgery. And on top of all this amazing work, you have performed over 7,000 cases, 3,000 valve surgeries, and published over 400 papers. And most notable is these key papers, Syntax and Partner, that are shaping our future of our specialty. And the other thing that I really want to highlight is we talk about MDT team working, and you are someone that works so closely with cardiologists. And I think that's admirable because our patients should be at the centre of what we do, and you're someone who does this. So I just want to sort of start by getting to know the guest and go right back to the beginning. Why did you study medicine?
First of all, you just listed a whole bunch of things that I've done, and all that means is that I'm really, really old. But I entered into medicine just because it seemed to be the thing to do at the time. There was no overwhelming passion because of a family member that had a disease or anything like that. Only one member of my family, my father, had completed college previously. I had to pick a major, and it was between pre-med and architecture. And I decided it would be more fulfilling to be a physician than an architect designing strip malls. So it was nothing more profound than that.
And look where you are now. And
yeah, shopping at strip malls.
Yeah, that maybe you could have designed better. Obviously, you then went into medicine. And at what point did you realise that you wanted to be a surgeon, and why?
It was a very late on decision. It was not like I had a grand plan and a grand vision. I went through medical school, and most of our education was by internists, internal medicine specialties, and the prevailing message was that we're the thinkers, we're the decision makers, and we tell the surgeons what to do. I drank that Kool-Aid for a while, and then found out that this really wasn't what I wanted to do. In essence, I was being a traffic cop of directing patients to other specialists that actually did something for the patients. So it was in the middle of my internal medicine residency that I decided that perhaps I wanted to be more actively engaged. I don't want to be critical of our internal medicine colleagues by any means, because what they do for patients in many ways is much more profound than what we do. but you have to be able to take a long-term vision that managing somebody's hypertension or diabetes or hyperlipidemias for a lifetime ends up translating to years of life. But for me, I needed a more immediate need gratification. I needed to go in the morning, do something, and at the end of the day, see what I did. And that's why I switched into surgery. And then once I went into surgery, again, it wasn't clear that I was going to go into thoracic or cardiac surgery. I looked at all the specialties, decided that late on in my general surgery training, that cardiac surgery is what I wanted to do.
It's so nice to hear that because, that's similar to my journey. It wasn't clear cut from the start. And as I started treating patients, it was, similar resonance. What was it about cardiothoracic surgery that that interested you? What made you make that decision and go for it?
Well, to you, this will be ancient history, but it was really alive and vibrant at the time. I went to university in the late 1960s, my medical school training in the early 70s, and then surgery training in the late 70s, and then cardiac surgery training in the early 1980s. And it was the time where cardiac surgeons were on the covers of news magazines, Life magazine, Time magazine, Denton Cooley, Michael DeBakey, Jarvik and the Total Artificial Heart. They're larger than life, I guess is the best way to say it. And who couldn't be in awe of those individuals? And I wouldn't say I made a conscious decision because of that, but in retrospect, it had to have some influence that sure would, I would love to have a career, a tenth of what that was for those individuals. So I think it was the profile of the specialty because of the onset of cardiac surgery and then subsequently, heart transplantation and the total artificial heart.
Yeah, and I think that it's just that having those role models out there, even if you don't intentionally know it, having these people that are just showing what they can do is just so important, I think, for all specialties. But once you find your niche in those people, and actually some of those stories and reading about those stories is why I chose cardiac, or what concreted it for me. So it's still having the same impact, even though I wasn't living through it. Mm-hmm. And did you see yourself at any point in your medical career early on becoming such sort of an academic surgeon, or was this something that you did fall into by chance, or was research something you were always interested in?
So I would say I took a non-academic path to get to where I am. And when I went through training and was finishing training, all I wanted to do was operate. It's what I spent my life and career learning how to do. I wanted to operate, and I didn't want to teach somebody else how to operate. I wanted to do it myself because that's what I've been training for. So I went into a private practice situation, not an academic environment, and spent the first 10 years doing nothing but surgery. But then one of my colleagues at the time said, you know what, we should start a research institute. And I said, well, why would you ever want to do that? And he said, well, there's something more to our experience than just doing another surgery and another surgery. Although that's great, there's probably a greater good that we can do. And we have a number of advantages to be able to do this. One is we're in a private practice situation where we have all the patients you could ever want to treat. And secondly, we didn't have all the encumbrances of an academic environment. We didn't have a dean's tax. We didn't have a whole bureaucracy that was constraining us what to do. So we started our own research institute, got involved in very large trials very early on, and became the largest enroller in these trials because we had, a significant number of patients. And so we kind of found the perfect sweet spot of clinical surgery and academic output because we had the best environment for it.
It's great that, you again, it's so inspirational that you've not come through this traditional academic route, but you've proven that actually just by having a bit of passion and a bit of drive, you can still achieve things, and you can, set up your own institutions. I think that's really nice to see, because for some people, they don't have that environment around them.
And I think that was an early lesson. I mean, that's been a recurring theme throughout is don't always accept things the way they are. Think outside the box, wonder whether there's a way to do something differently. And again, this wasn't an epiphany that I had by any means. It was one of my colleagues that had the idea. And like many times in life, you hear an idea, your first reaction is that's crazy. And then you sleep on it overnight and you say, you know what, maybe that's not crazy after all.
Yeah.
And that's kind of how we started down that path.
So listen to your friends with the crazy ideas sometimes. It'll pay off long term.
Yeah, you got to pick your friends carefully, though.
Yeah, true. So I thought we'd get sort of into more of the nitty gritty of this. And the first topic I want to touch on is this whole sort of TAVR versus SAVR. To start with, I thought I'd give a bit of a background to TAVR versus SAVR, especially for our medical students and newer trainees who haven't had any exposure and don't really know the terminology. In the UK, TAVI and TAVR, so we call it TAVI. In America, it's much more TAVR, and it stands for Transaortic Valve Implantation or Transaortic Valve Replacement. The first studies on animal studies was back in 1989 and human studies 2002. So actually, for lots of attendings or consultants that are working today, some of the older generation, they will have watched this come into play. This wouldn't have been around when they were studying medicine and beginning their training and beginning their work. So it's, such a new technology still, really. The other thing is that when we look at the annual growth of TAVR is about 7%, and we always talk about how rapidly expanding it is. But actually at the moment, for surgical replacement, for SAVR, it's about 5.5%, so it's not too far behind it. And you gave this wonderful talk, Dr. Mack, recently, and I listened into it, and you made it really clear about why we've adopted TAVR so rapidly, and talking about that it's easily teachable, it is evidence-based, and it's user-friendly. And one of the big things we talk about evidence-based is there's been so many trials that have looked into this. I just kind of want to sort of start by saying that some people say that cardiac surgery is dying and interventional is going to take over. Actually, this might not be the case, and it's just our surgical, who we're operating on and what surgeries we're doing are going to change. But over the next sort of few years, the next decade or so, what are those biggest decisions that the heart team are going to have to make when it comes to whether they're choosing TAVR or SAVR for their patients?
Okay, so this really is a 4-hour answer to all that, but I'll try to make it concise. And first thing I would say is, the history of thoracic surgery is staying one operation ahead of extinction. And that's been true ever since it became a specialty that was treating tuberculosis and on to rheumatic fever, coronary disease, bronchoscopy, pacemakers, et cetera. So, nobody should be concerned about the future of cardiac surgery. It's just evolving on to the next thing as things that we've done in the past have become less invasive and don't require the same surgical expertise. But let me go back and start with TAVI versus TAVR, because I was there in the room when the US decided to call it TAVR. And it wasn't like our current environment by any means that that we're going to be Americans and we're going to do something different than the Europeans. It started out as TAVI, and then it came to the US, and we were in a meeting with Medicare. which is the government payer in the United States. And they say, well, we don't have a code for valve implantation. We only have coding for replacement. And we said, okay, but this thing's already called TAVI. And he says, well, that's fine. You can call it TAVI if you want, but you aren't going to get paid for it. The only thing we can code for is replacement. So that's where TAVR came into being. It was just so that Medicare in the United States would reimburse for the procedure, and it was nothing more than that. But my history with TAVR dates back to about 2000, and the first human had not been done yet. I went out with a number of my colleagues to an animal laboratory at Edwards Life Sciences in Southern California to see this new procedure that was being developed. And it was a transapical TAVR in a sheep. And I must say, there's so many things in life you see that you say, aha, why didn't I think of that? I've never apologized to myself for not inventing TAVR because I knew all the failure modes. I knew all the reasons why it couldn't work. How can you put in a valve without actually seeing it? How does it stay in place without sewing it? Surely you got to cut out the old valve. Well, all that calcium's going to go to the brain. And boy, how do you get a valve in without, crushing it up? Surely that's got to damage the valve. And so I didn't think enough outside of the box. But once I saw it, it took a microsecond to connect the dots and say, this is really going to work. Now, to be fair, at the time, I had no idea what the impact of it was going to be. All I knew is that this had a chance of working and was going to be a realistic alternative to patients who weren't surgical candidates. And then the next decision I made is I had lived through the 1990s, which was an incredibly divisive time between cardiac surgery and cardiology. It's when coronary intervention came into being. We spent a lot of years in patients having dissected left anterior descending coronary arteries from plain old balloon angioplasty, taking patients to the operating room, pumping on their chest when it was something, if they, an elective situation, they could have just had a lima to the LAD and live happily ever after. So it was a very divisive time, but we all know how that sorted out. Stents eventually came into place, fixed the dissection problems, then dual antiplatelet therapy, et cetera. And now 3 out of 4 of every patient undergoes coronary revascularization by the less invasive approach. So fast forward, now it's the year 2000 or 2001, just before the first in man. And I said, you know what? I think I know how this story ends. So the options are I can ignore it. I can pretend it's not going to be successful, can put my head in the sand and hope that it doesn't happen. I can fight it, or I can be in the game. And the only way to influence a game is by being in the game and playing it. And so that's the route I chose based upon my previous decade of experience. And that's kind of been the history of my involvement in it. You alluded to the fact that, there are 3 major drivers of adoption of any new procedure or drug, mainly procedure in clinical medicine. One is a clinical unmet need. 2 is a strong evidence base. Third is it has to be user friendly. And the 4th is teachable. I would say the evidence base was so strong and the companies did such a good job of training and making it user friendly that it was almost a fait accompli because it checked all of the boxes. Now, the industry and the clinical trialists deserve credit for developing this strong evidence base, but the real credit goes to the U.S. Food and Drug Administration. Uh, they they dictated what the evidence needed to be for approval in the United States. And it started with inoperable patients, high risk, intermediate, and low risk. So I always give the FDA a lot of credit, because unless they held everybody's feet to the fire, the evidence base wouldn't have been as strong as it was. And because it's so strong, the adoption has been so great. The other lesson there is that in order for a procedure to be scalable, it has to be user friendly. People have to be willing, there has to be a strong reason for people to get out of their comfort zone from what they've always done and do something else. And it either has to be better, or it has to be easier or quicker or something else. We hear a lot about the Ross procedure nowadays. And I'm a strong fan of the Ross procedure. I've been through two waves of it now. But if you look last year, there were about 110,000 TAVRs done in the United States and about 700 Ross procedures. So if you've got to be a master surgeon to conquer the technical complexity of a procedure, then it's not widely scalable. So one of the challenges we have now as surgeons is, how do we make the Ross procedure simple so that it is a viable, scalable, long-term solution for many more people than the 700 that are getting it in the US right now?
That was actually going to be one of my next questions, was that we are seeing this sort of resurgent of the Ross procedure at the moment. And I think you just make it so clear about, what we need to do with it to make, it stay and make it, a really viable option. Because not, in the UK, not all centres often offer it. And therefore, patients can often be pushed, down one route or the other when there is a third option for them. So, yeah, it's really interesting, and that thinking outside the box at how can we make this user friendly. If we, think about surgical replacement in itself, obviously it's going to be around to stay, but we're talking about more complex patients. We're still going to be using it with our younger patients, people who need their roots doing things like this. What differences do you think we'll see with the surgical replacement? Is it more minimally invasive? Will the full sternotomy die out? Where is it heading for the surgical replacement?
A couple of thoughts there. We've been fans of the mini sternotomy for quite a number of years. And there is significant patient appeal to that. That being said, and there have been multiple randomized studies, including one that we did, as well as looking at sub-analysis of the partner trials that show that there's no benefit to a mini sternotomy compared to a full sternotomy, either in terms of time to recovery, narcotic use, pain levels, etc. However, the small incision does have patient appeal. When you have a younger patient and they are not a candidate for TAVR for whatever reason, heavily calcified bicuspid valve, age, etc., they're of course disappointed they can't get TAVR. But when you can tell them you can do it through a tiny incision here, then a lot of the disappointment goes away. Now, I will say something that I missed was the role of robotics here. We were early adopters of robotics, and we abandoned it early on because I really didn't see the advantage to it. And then when the second wave of robotics came, we got back involved with it, and it is our default way of performing mitral valve repair. However, I never saw a role for it in aortic valve replacement. And recently, on the example of Vinay Badwar and others, that have started this. We sent a team to West Virginia. They saw 3 cases, came back and doing it. I must say, I think a couple of incisions on the side and doing robotic aortic valve replacement, although, the times are still longer at this point. We're never going to demonstrate a benefit, but again, there's enormous patient's appeal. And I think the less invasive we can make a procedure, the better alternative that we're offered to the patients. If you have 2 procedures and the outcomes are roughly the same, the less invasive procedure is always going to win out over the more invasive procedure. So our role in patients that like this are to make a procedure as less invasive as possible, as long as you don't compromise the procedure. So I think that's one. But secondly, as you've alluded to, surgery is only going to get more complex, which is, again, the natural history of cardiac surgery over the years.
I really like that point about the fact that if you've got 2 equal treatment options, people are always going to choose the most minimally invasive. And as much as we think they may not, if you or I were offered 2 options, of course I'm going to choose minimally invasive over a giant cut. It seems, how we think that patients won't is, yeah.
I'll use it as an example. The one thing that's been done in cardiac surgery and cardiology for that matter, that prolongs survival is a left internal mammary artery to the left anterior descending for proximal LAD disease. Yet, how many patients are lining up to get that as first line therapy? Virtually nobody, including me. If I had a proximal LAD lesion, I'd take a stent first. And if the stent failed, then I'd get a LEMA to the LAD. I made the transition once I realized that if I had a stent, I wasn't going to come back with a stent thrombosis and die from it. I could still get a LEMA to the LAD. And so once that became in place, then my mindset switched. And even though I can get a procedure that would prolong my life expectancy, I'm going to take the less invasive procedure until I absolutely need the LEMA to LAD.
And we can't really have this discussion without really sort of talking about the partner trial and sort of where we're going in research and what's going to go, what's coming next. And the most recent publications of it shows that these lines are beginning to diverge. I know you've talked in the past about sort of long-term follow-up. And like we said, the first TAVR patient has only had it, it's 23 years. So we don't have really long-term data. Do you think long-term data will change our practices at all? Do you think that we may end up reducing the numbers of TAVR ever, in proportion, the ratio to surgical?
A couple things. From the partner trials are all going to, patients are all going to be followed up for 10 years. And we have 5-year follow-up on all the trials now. And we have longer follow-up on some of the intermediate risk patients. The problem is that when you go farther out, after 5 years and approaching 10 years, patients die from other reasons. The mean age in the Partner 2 trial was 81 years old. If you're going to follow those patients, how many patients are going to make it to 91 independent of their aortic stenosis or their prosthetic valve in place? In the Partner 3 trial, which is the low risk trial, the mean age was 73 years old. Well, now the majority of those patients are approaching 80, and what we're seeing is significant attrition that has nothing to do with the valve. So that's one. So I wouldn't necessarily hold out saying that we're going to see divergence of curves and have a clear answer as to what we should do once we get 10-year results. The second thing is, this would be the first time that surgical valves have been systematically studied. Also, there has been no routine surveillance of surgical valves until now. We always say that surgical valves, bioprosthetic valves, last an average of 10 or 15 years. And the definition of that is reoperation free survival. But we never systematically followed those patients or surveyed those patients out of a couple single center series. So that's the second part. The third is, let's just say that we get 10 years out and we find that a surgical valve lasts 2 years longer on average than a TAVR valve. Is that really going to make any difference to a patient? Probably not. They're going to say, you know what, I still want the less invasive procedure, and I'll worry about what's next 10 years down the line.
Yeah, I think that's a nice point, actually, because, 2 years for patients, in their 90s might, whereas their difference of what they experience at the time of operation, it's the patient's quality of life at the end of the day. So with regards to the aortic valve, I know there's future research is looking at use of TAVR in bicuspid valves, because that's never been studied, and use in asymptomatic aortic stenosis. Where is the future of research going with regards to all of these? Can you just give us, I know there's a lot going on at the moment, can you give us a sort of a brief overview of what's going on at the moment and what the grey areas are and what you think needs to be tackled?
Well, you brought up bicuspid aortic valves, and that is an area of a strong interest in research. And the reason being is that bicuspid valves were not included in any of the pivotal regulatory trials. However, at least in the United States, TAVR is approved for bicuspid valves without them ever being included in the trials. And, we know that there are some bicuspid valves that can be treated with TAVR and they'll do just fine. We also know that there's some that shouldn't go to TAVR, heavy, eccentric calcification, calcified median raphe, calcium extending into the LVOT, concomitant aortic dilatation, but we don't know where the line between those two is. So there are a couple of proposed trials right now. One, a multinational trial headed by Stefan Windecker and Matthias Seppa from Bern, called the Navigate trial, that we're anxious to participate in if we can find enough funding from about 10 different countries right now. UK is hopefully going to be one of those countries. There's another trial called the Believers trial that Raj Makkar from Los Angeles is trying to get funded. So hopefully we'll see that. You mentioned asymptomatic patients. We have 2 surgical randomized trials that show that asymptomatic patients with very severe aortic stenosis do better with early surgery rather than intervention. And we have the early TAVR trial that shows that although there's no mortality difference, most patients convert within 6 months to a year to surgery anyway. So the conclusion being, why wait, since you're going to conclude anyway? To me, the takeaway of that trial is you can defer to patient preference. You can justify doing it right away, or you can justify waiting because there's no penalty of death either way in that trial. I think the next trial that we'll see in the aortic valve space is TAV and SAV versus reduced SAVR. Michael Borger in Leipzig has been promoting this idea for years. And I agree with him. The problem is there isn't a strong enough evidence base as to the durability of TAV and SAV. The second valve is not going to last as long as the first valve. But it's a trial that hasn't been doable until now, because again, we talked about invasiveness. Patients aren't going to say, okay, so you're telling me I can put another valve inside my old valve through an artery in the leg and go home the next day, or I can have a sternotomy, you know, and spend a week in the hospital and 6 weeks getting better. I don't think I'll sign up for that. So I think the equipoise hasn't been there, but I think over the next couple of years, there will be enough evidence that the second TAVR valve, a valve in valve, doesn't last nearly as long as the first, that we will get to the stage of doing a randomized trial on that.
Good. Yeah, it's nice to see that we're recognizing our gaps. And yeah, a patient who's already been through a stenotomy and knows the whole sort of the journey of it, they might be like, oh, hang on, I don't want to go through that one again. Let's go for something else. So yeah, it's nice that we're recognizing these gaps. We have covered the aortic valve there in depth. I'd also quite like to just discuss what are our options for mitral and just briefly on tricuspid as well, because this is, you know, another big area that we're seeing this change just from purely surgical to the interventional side. As a bit of a background, actually, we talk about TAVR, so transcatheter end-to-end repair. And this actually began to be developed around the same time as TAVR. It was only a few years behind it. But we're only performing around 14,000 of these in the US compared to over 100,000 of the TAVR. And it's not eclipsed the surgical repair. And one of the reasons is as you mentioned, there's less evidence, it's less user-friendly, more difficult to teach, and it's not just a single disease that we're treating, there's a lot of variability. What's going on in the field of this MitraClip versus mitral repair?
So first, I'll again refer back to our colleagues at CMS. They're the ones that came up with the name TEER, transcatheter edge-to-edge repair. And I must say, none of the clinicians or sponsors thought of that. It came back, and I think it's a perfect description of the procedure. So again, I give them credit for thinking of that. So I think you've alluded to a number of the reasons why. It's a more mitral regurgitation. First of all, you have to separate into primary and secondary. Secondary, I think the role of any intervention, be it surgery or TEER, is still open to question, especially in the minds of the heart failure community. And oh, by the way, guideline-directed medical therapy for secondary mitral regurgitation has gotten really, really, really good. So I think we're focusing mainly on primary mitral regurgitation. Having said that, TEER was not an aesthetically pleasing operation to me. Most transcatheter procedures take a surgical procedure and make it minimally invasive. Yeah, this is done off of the Alfieri stitch, and it was actually Dr. Oz, who is now head of Medicare in the United States, that visited Alfieri and has the patent for the MitraClip. It didn't make a whole lot of sense to me that you could do that routinely. Having said that, the results are much better than I ever thought that they would be. It is a more complex disease. People don't die from it. If you have a failure from a transcatheter TEER procedure, patients just have more heart failure or more symptoms, but they don't die from it like you do from aortic stenosis. And there's multiple different causes, which mean multiple different solutions. There are 2 trials that are ongoing right now, the Repair MR trial in intermediate risk patients and the primary trial, which is sponsored by the NIH in the United States, CTSN, the UK, Canada, Germany, Spain are all part of this trial. We're in the final stages of enrolling patients in that. These are low-risk patients. And we decided we needed to do this trial while there was still equipoise out there, so that when we have the answer 5 years from now, the trial was still enrollable. So I think that's going to be something that, it's going to be a minimum of 3-year follow-up, average 5-year follow-up, and it will be completed enrollment early next year. So I think that's something to look forward to. That'll give a lot of answers. Tricuspid valve disease, my concerns there are, yes, you can correct the tricuspid regurgitation, but does it make any difference in the patient's survival or quality of life? The trials so far have just shown an improvement in quality of life. I'm concerned that that improvement will not be sustained long term. I think in the majority of patients, or a significant number anyway, TR is a marker of right ventricular dysfunction. Fixing it may not make a difference. I think we're seeing right now a re-experience of the early surgical experience from 10 or 15 years ago, about there are cohort C patients which are futile, those on dialysis, those with end-stage liver disease, that we learned in surgery 15 years ago, you could do a perfect operation and the patient wasn't going to survive. We're seeing the same thing all over again now. So I must say the ballot's still out. I think there is a lot of untreated tricuspid valve disease out there, but I'm still skeptical that we're going to make any difference in long-term survival by correcting the TR.
Interesting. Interesting. And this study you mentioned with the mitral, just to touch on that again, is that comparing interventional to surgical?
Yes, the primary trial. Yes.
Yeah.
Yeah, it's TEER with either of the two devices, either MitraClip or Pascal, versus surgery.
And that's talking about surgery in general or minimally invasive robotic. Are they included or are they excluded from this?
They're included. So it's surgeon choice as to which way you want to do it.
Because my next question was going to be, is the mitral valve actually, maybe we'll see in the future that the robotic minimally invasive is the one that's going to sort of reign over everything else rather than the endovascular or a large open stenotomy?
Well, I think if we look at our own institution, and we do about 250 mitral valve repairs a year, about 2/3 are done by a robotic approach and 1/3 by a mini right thoracotomy, with very few done by a sternal open sternal approach. And I'd say that's the way most institutions are going. But I think it is a lesson in surgery that in order to do any of these less invasive approaches, you got to be able to be competent at repairing the mitral valve first before you go to a minimally invasive approach. That shouldn't be the way that you're learning.
If everyone's turning towards a minimally invasive robotic route, and we're saying that this is the best for our patients, and we are not doing a stenotomy to do it, but we need to be able to, as a trainee, be able to do it competently open before we do minimally invasive, is there not going to become a point where it's really difficult to learn?
It is a challenge. There's no question about that. But there's, a lot of operations that are still done open and need to be done open, such as double valve replacement, endocarditis, cabbage plus valve procedures, etc. But, think of it this way. How many general surgical trainees know how to do an open Whipple procedure or an open colectomy? How many vascular surgeons know how to treat a ruptured abdominal aortic aneurysm by an open approach? Because everything's gone minimally invasive in both of those specialties. And it's the same type of thing here. It is challenging to teach trainees how to do it, but there's enough open procedures that are done that's where you need to learn the techniques and then figure out how to do it through less invasive approaches.
So take those opportunities when it's a double valve or a valve and cabbage to learn and then later on develop it. we've covered so much and it's been amazing, and we've really talked about what's going on at the moment, but we need to think about the future in general, not just specifically for the valves. And, where is cardiothoracic surgery or cardiovascular sciences progressing? And in the talk you gave, you talked about the role of AI and the development. And actually, we're beginning to diagnose valve disease much earlier. So will we be intervening a lot earlier? Things like AI, user ECG interpretation, POCUS, genomics, even digital stethoscopes, things like this, are really helping. And also our medical management of some things is really developing, as science shows, and the identification and timely treatment of these. So in terms of sort of AI and that aspect of where our specialty's heading, what can you say?
I think AI is not just hype. It's real and it's here and it is going to make a profound difference. The initial applications in medicine are all backroom operations where it is making a difference. So in a hospital or healthcare system, it's billing, it's operational logistics, it's reading contracts, filing insurance payments. That's where it's all being applied to begin with. As it moves into the clinical space, it's such areas as ambient listening. AI is listening while you're taking a patient history, and you can look a patient in the eye and not have to be focused on entering your data into an EHR because AI is doing that for you. So that's the way where we're going to see it patient facing. Where it's ultimately going, however, is algorithmic patient care. In other words, you take a patient with a certain age, with a certain set of symptoms, with a certain genomic profile, and you will be able to predict whether that patient is going to do better with SAVR or TAVR, for example. Care will become much more algorithmic. You'll be able to predict better when the best time to extubate a particular patient is. It's going to be, on one hand, less individualized and more protocolized, but on the other hand, truly a personalized medicine, because you'll be able to predict, well, yeah, we know that we usually extubate patients, within 4 hours after surgery, but due to this patient's postoperative circumstance, this one's not ready to be extubated, that we're going to wait 6 hours instead of 4 hours, or whatever it is. So that's where I see it's going to be in patient selection for which therapy, as well as prediction of long-term outcomes. You're going to be able to say, this patient is a 64-year-old female with aortic stenosis and LP little a. And, that patient is going to need long-term treatment of her hyperlipidemic disorder to prevent early recurrence of this, and she's going to live an average of 15 years afterwards. That's where it's really going to go,
I think
as
that's
well as all the early diagnosis, like you mentioned.
mm. And I think that's just so important because, we need to be able to offer our patients the best treatment, and we need to be able to give them sort of realistic outcomes and to help them make their decisions, because, like we said, it's a big challenge. I want to just round up by thinking about our population that listens to this podcast is medical students, trainees, residents, all these kinds of people. It can be quite daunting as a trainee, and I know there are lots of people that are really concerned about the future of their specialty and their career because, yes, there'll always be cardiac surgery, but it's going to be, the cabbages aren't going to be simple. They're always going to be a challenging one. The valves are always going to be challenging, and it's a different specialty to what they maybe thought it would be. What advice can you have for a trainee to stay ahead of that curve and to, you said about embracing this new technology, and if you've got to be part of the game to really, to stay in it. What advice would you give to trainees like early in their careers?
So a couple answers there. We went through a period in the early 2000s where the future of cardiac surgery didn't look bright. I remember debating a cardiologist in Vienna, Patrick Sorice, that said coronary bypass surgery will be dead in 10 years. And that was 1999. So here we are, and there's still 160,000 done per year in the United States. And I've just gone through guidelines and appropriate use criteria. CABG isn't going away by any means. But because there was this concern of it in the mid 2000s, a lot of trainees didn't go into cardiac surgery. Training spots didn't fill. And right now, we're suffering from not enough cardiac surgeons to fill the spots that are needed in the United States. So it's undergoing market correction now. But we don't have enough surgeons to fill the spots. Now we're getting, now the training spots are all full again. And I don't think anybody should buy into this doom and gloom. There's not a future of cardiac surgery because of minimally invasive. Of course there is. My advice to trainees is focus on one particular aspect that you really love and are going to get compassionate about. And maybe it's valvular heart disease, maybe it's advanced heart failure, transplantation, and LVADs, or maybe it's coronary disease. And I think one of the mistakes we made in the specialty is we didn't treat CABG as a specialized procedure. We treat it as something everybody does. And I have been on record many times, and I'll continue to be on record saying it is the most technically challenging operation we do in cardiac surgery. Why aren't we focusing on it like we do mitral valve disease or aortic valve disease or cardiac transplantation? It's the most common procedure that we do, but we don't treat it as a specialist procedure. And we need to. What I would say is pick an area that you're going to get really, really good at. And it can't be an area that your chief tells you, well, we need somebody to do this, and why don't you do this? But you hate doing that. Pick something that you can get passionate about and become the best that you can at it. And then ride that horse for the rest of your career. I think that will serve a trainee well.
I think that is a actually really nice place to end this discussion, because I think it just, it's inspiring to know that someone who's been through it all and knows so much is not scared about the future, knows that we're around to stay, and is optimistic but has good insight into how, as a surgeon, you can keep your longevity. And I always like to ask my guests this question of, if you could go back to yourself at the beginning of your training, in general, talking about just training as a cardiothoracic surgeon in general, what advice would you give yourself?
Precisely what I just said is pick something that you can get passionate about and then live and breathe that. I don't think you can be a generalist cardiac surgeon and do it well. The second is always find yourself a mentor that you can rely on, that you can reach out to anytime. One of the epiphanies that I would say a lot of my career, I kind of said, well, I'm a card carrying cardiac surgeon. I know how to do this, and I should be able to know how to do this without reaching out. Well, I found out every Fortune 500 CEO in the world has a coach or a mentor that they use for it. So why don't we? So second, always have somebody you can reach out to and rely upon. And then third, always take a step back and be introspective. I think we're pretty good about keeping all the balls in the air and juggling at the same time. And we probably don't do as good a job as we think we do when we're in the moment. So it's always worthwhile to step back every once in a while and look at it and saying, am I really doing as good a job as I think I'm doing? So those would be my 3 pieces of advice.
I think they're a wonderful piece of advice, and I think it'd be really useful to our listeners. Thank you so much for being on this episode, Dr. Mack. It's been a really nice talk, a really inspirational talk, and just so valuable to learn what's going on and where we're going with this specialty. Thank you.
Thanks for having me, Alice. I very much enjoyed talking with you.
No problem. So thank you everyone for tuning in, and stay tuned for our next episode.